Okay, we're moving on to prenatal care and what high quality prenatal care should look like. So for low risk patients, prenatal care appointments should begin somewhere in the first trimester. They usually start at about 9 weeks or so. Some women will go earlier, especially if they're considered high risk, but then they should continue every 4 weeks until about week 28. That's when we step it up a notch. They go every 2 weeks between weeks 28 and 36. After 36 weeks gestation, patients should be seen weekly for prenatal care. And it's important for mom to maintain that schedule. Some women will think, well, they don't do anything during my prenatal visit. I step on a scale, they listen to the baby, they take my blood pressure, and that's it. Well, that's not really true. And moms should be educated as to, what are the risks of pregnancy and, why it's important to continue with normal prenatal care. So the first prenatal visit is the longest. They're called new intakes. They should include all kinds of screening and assessment. So health history, do you smoke, do you drink, where do you work, are you exposed to anything hazardous to this pregnancy, do you have any pre-existing conditions, diabetes, heart disease, hypertension, anything like that. So we can calculate some risk factors for mom. We're also going to get an obstetric history. How many times have you been pregnant? A little more about that in a few seconds. And then we're going to determine mom's due date using one of three methods. Two rely on the last menstrual period, and one is done by ultrasound. We're going to find out what medications or supplements are being taken by the patient. And in many cases, we're going to have to educate patients about that. Psychological response to the pregnancy, we're going to make sure that mom is safe. We're going to do an IPV screening or intimate partner violence screening. We're going to make sure that she has access to food, that she has housing and running water and electricity, that she has a way to get to her prenatal appointments, that she has support at home. And we're going to assess for other kinds of risk for genetic traits. We talked about that in the last module, who's appropriate for genetic screening. So moms who are over 35, moms with certain ethnic backgrounds like Ashkenazi, Jewish ancestry, moms and dads with history of inherited disorders will be referred for genetic counseling, and people with multiple losses. Laboratory tests, we're going to get a blood type and an RH factor. The RH factor tells us if mom is RH negative, in which case her baby is at risk for RH incompatibility. Topic for a separate video, but she may need RhoGAM at 28 weeks. We're going to test for HIV, gonorrhea, chlamydia, hepatitis, and in some places we're going to test for other diseases based on mom's risk factors. Patient education will include health promotion, what to expect in the first trimester, second trimester, what things she should avoid that are teratogenic. So, for example, there are certain foods that should not be consumed because they are high in mercury, like seafood of certain varieties, or raw cheeses, unpasteurized foods. She should be taught to avoid exposure to tobacco or secondhand smoke, alcohol. Signs and symptoms that she should report to her provider, and I will go over those in a minute. And mom should be provided with written materials at a fairly simple reading level in the language that she understands best. It's important to assess both health literacy and reading literacy at this visit so that you know how mom should be educated. Now we're going to talk about how we classify an obstetric history. So this is the history of mom's pregnancies. A nulla gravida has never been pregnant. Prima gravida, this is her first pregnancy. And a multigravida has been pregnant twice or more times. And that's kind of important in assessing how the pregnancy is going to go. There are certain features of pregnancy that will be different based on these three factors. And also mom's educational needs will be impacted by that. And then we have the word para or paris, which pertains to giving birth. A nulliparous woman has never given birth. A primip or primiparous woman is giving birth for the first time or has given birth for the first time, and a multiparous woman has given birth more than once. So those are some terms. And then we classify it further with a system called gtpal. Sometimes on the units you'll hear just gravida para. That's fine. G is gravida. How many times has she been pregnant? T is for term births. Twins or other multiples count as one birth. So that's the tricky one. These are term births occur at 37 and 0 days gestation, weeks, 37 weeks, 0 days to anything beyond that. Preterm births, again, twins and other multiples count as one birth. These are births or losses from 20 weeks and 0 days to 36 and 6 days in gestational age. So if mom had a fetal demise at 21 weeks, it counts under the P. If mom had a set of twins at 36 weeks, it counts under the P as one. Abortions or miscarriages, any ending of pregnancy prior to 20 weeks. So from conception to 19 weeks and 6 days is under the A column. And then for L, we have living children. And that gives us a lot of really important information. If mom's had a lot of losses or elective terminations, it will influence how we care for her in terms of assessing risk for preterm labor. If mom's had preterm births previously, it also impacts her risk. I'm going to give you an example. We'll work it out together. The woman presents for prenatal care at the clinic. So she's pregnant. She went for prenatal care. This counts as one for your G. You can keep a tally as I'm talking if you want. Prior to that, she had 2 spontaneous losses at 9 and 12 weeks respectively. So we have 2 more G. Now we're up to G3. And in the A column, put 2 tally marks. Next, she gave birth to 35-week twins 4 years ago. Okay, so these are preterm because they're 35 weeks. It counts as one birth. So give yourself another pregnancy. We are now at G4. And put 1 tally mark under the P column for preterm. And she had a 39-week singleton 18 months ago. So that is a T. So give yourself 1 more slash mark for G. We are up to G5, and we are up to T1. One of the twins died at SIDS at 4 months of age. So we have 3 children made it to term. 1 died. We have living 2. So we have G5, 5 pregnancies. The present pregnancy, the 2 spontaneous losses. That's 1, 2, 3. The preterm twins counts as 1. That's 4. 39-week singleton, that counts as 5. We have 1 term baby born at 39 weeks. We have 1 preterm birth at 35 weeks. We have 2 abortions, 9 and 12 weeks. It is a spontaneous abortion, also known as a miscarriage, and she has 2 living children. Sometimes it's shortened to gravidipara. If you were giving report on labor and delivery, you'd probably say she's a G5P2. Next, we're going to learn how to determine a due date with Nagel's rule. This is a quick way to do it. You ask mom when her last menstrual period was, you subtract 3 months, you add 7 days. Now, obviously, you would add a year to that because nobody gives birth 3 months before they got pregnant. But we're not going to get that silly. So for example, mom had a last menstrual period of March 17th. We're going to go back 3 months. We're going to go back. 1 month is February, 2 months is January, 3 months is March. Oops, I misspoke. Let me just say that again. So 1 month would be February, 1 month would be January, 2 months would be January, 3 months is December. We are in December. Then you add 7 days, 24, and your estimated date would be December 24th. That's how you do Nagel's rule. Next, you can do it with a wheel. I'm just going to play my little video here. Whoops. Okay, so I'm going to show you how to calculate a due date using a gestational wheel. And these are pretty handy to have. It's kind of like in a doctor's office and clinics. So what you do, you know, the last day, the first day of the last day, let's say it's March 17th. And line this line up with that date. And it tells you that what is the at the end of December 22nd. It's a little different from our Nagel's rule. If you know the date of conception, let's say mom had IVF and she had her conception was at February 14th. You then have this conception date. So that's a date of November 7th, which is the same as what we did. Sorry. Okay. Now I'm trying to move on. Sorry. Okay. So now we have subsequent visits. Prenatal appointments are going to include physical assessment. One of the things we're going to do is bundle height assessment. I'll talk about that in a second. But we're just going to make sure that mom appears physically well. We're going to get any history since the last appointment. Have there been any changes? What are the discomforts you're feeling? Are you feeling the baby move? We're going to get vital signs and weight. Particularly, we're interested in blood pressure. Remember that it is normal for the heart rate to rise by 10 beats per minute, and it is normal for the respiratory rate to increase by 2 breaths per minute. But it is not normal for the blood pressure or the temperature to increase significantly. And we are going to look at weight. Again, mom should gain about 3 pounds in the first trimester and about 0.5 pound for each trimester after if she is of normal weight. If she's gaining weight at a faster rate, we have to look, is this fluid? Are we looking at edema, which could be a warning sign, or is she just eating more than she needs to? Excessive weight gain in pregnancy is not a good thing. And so we're going to educate mom that 300 calories or 350 calories is really not that much. You're looking at, a half a peanut butter sandwich and a glass of milk most of the time, something like that. We can help mom with a nutritional consult if we need to. Also, at subsequent visits at about 10 weeks, we can hear fetal hearts. 110 to 160 beats per minute is normal. Sometimes moms like to guess whether it's a girl or boy based on the heart rate. It really doesn't matter. Fundal height, you take a tape measure. You go from the pubic symphysis to the fundus or the top part of the uterus, and it should be about 1 centimeter a week of gestation, starting at about 16 weeks. But we usually don't measure till about 20 weeks. And at each appointment, we're going to educate mom. And one of your things during class is going to be to educate mom about what's normal, what's not, and what to report to her provider, what lifestyle activities she can continue, and what things she should avoid. So, teaching about danger signs, this is important. In the first trimester, please report any bleeding, spotting, or cramping. Those could be signs of miscarriage. Any painful urination, especially if accompanied by fever, that's a sign of a UTI. And any lower abdominal pain accompanied by shoulder pain. The shoulder pain is sort of a diagnostic or a marker for an ectopic pregnancy. And hopefully, if we got an early ultrasound, we've seen that there's an intrauterine pregnancy, but that's another topic for another day. More danger signs in the second trimester, and this continues throughout term. Any regular pattern of painful contractions. They may feel like cramping in the lower abdomen, or they may feel like cramping in the lower back that come and go on a regular basis. This is not just the tightening of the uterus you get with Braxton Hicks. But in any case, in the second trimester, if mom is contracting more than 6 times in 1 hour, she needs to call her provider immediately. New onset of back pain, as I mentioned, sometimes preterm labor feels like back pain. So if it's not just that achiness when you're standing for too long from the lumbar lordosis, this needs to be reported. Leaking of fluid from the vagina, she may hear or feel a sensation. She may have a pop and a gush, or she may just have a little trickle. Vaginal bleeding is not normal during pregnancy. Sometimes after sex, women will report a small amount of vaginal bleeding, but it should still be evaluated. And any decreased fetal movement, particularly if the baby's not moving for like 12 hours, she needs to come in and be seen, make sure that baby is okay. More danger signs, sudden weight gain. This happens as a result of preeclampsia. All these are preeclampsia signs. Swelling of the face, hands, and eyes is not normal. Swelling of the ankles is kind of routine, but face, hands, and eyes, not normal. She should be seen by a provider. She suddenly looks in the mirror and says, wow, my eyes are really swollen. Epigastric pain. So we don't tell mom epigastric. We just point to the spot and say, if you have pain here up high in your abdomen under your ribs, that is a sign of preeclampsia as well. Again, a topic for another video, but these are things we teach moms. Severe headache, unrelieved by Tylenol or rest, or visual changes, floaters, double vision, blurred vision. Some diagnostic testing that we might do during the prenatal course. Ultrasounds, very common. Most women have about 3 or 4. We can use them to confirm and date a pregnancy. We measure the baby. The earlier you use ultrasound to date a pregnancy, the more accurate it is, because there's not as much variation early on. So if you get a crown to rump length, which is the top of the head to the tailbone, it's usually pretty accurate. Later on, babies grow at different rates. They take after moms and dads in terms of their size. It's not as accurate. We can use ultrasound to detect a multiple gestation. We screen for anatomical defects. Anything that would be apparent on ultrasound usually gets picked up. Imaging technology is really good. We use it for first trimester screening to screen for chromosomal anomalies and neural tube defects. And it's also used in biophysical profile to assess fetal well-being. It can also be used to obtain fetal heart rates when you're having trouble getting them via Doppler or fetal monitoring, or to confirm a fetal demise, but that's another topic for another day. We may do genetic testing, and we touched on this in the last module. CVS, amniocentesis, non-invasive prenatal testing can all be offered to moms who want it or are at risk for it. CVS and amnio, remember, are invasive, so we really don't offer it unless there's a good reason to do it. Then there's the quad screen. This happens usually around weeks 16 through 20. It is blood testing, mom's serum, and we look for certain markers. Alpha-fetoprotein being the big one, spina bifida and neural tube defects, because there's leaking of cerebrospinal fluid, you'll get more protein. And then decreased alpha-fetoprotein is a marker for Down syndrome. It's not diagnostic. A lot of false positives. Moms get freaked out, but they should be offered further testing. Then we have every mom should be screened at about 26 to 28 weeks for gestational diabetes, sooner if there's a strong history. The patient drinks this stuff called glucola. It looks like orange Shasta. It's really nasty. It's so sweet. Makes a lot of people nauseous. Then we wait an hour. Does not have to be a fasting test. If it's greater than 135, we refer for a 3-hour glucose tolerance test, and that is covered under diabetes in pregnancy. That is a fasting test. We test for group beta strep at about 36 weeks. They swab the vagina and rectum. It is not an infection. We treat with penicillin during labor, again, a topic for another day. Another test that we might offer to mom is a non-stress test. And this is when we look at the baby, and when the baby moves, the heart rate should go up. We should get 2 periods of fetal movement. You see them here. Look at my pointer. And it corresponds with an increase in the heart rate. Just like if you walked up a flight of stairs, your heart rate would go up slightly, then it returns to baseline. That's a non-stress test. If it's a flat strip, if we don't see those rises in the baseline, we can wait 40 minutes. We can try and stimulate the baby with having mom drink a little juice, or using like a buzzer to wake the baby up. And if that doesn't work, we refer for further testing, which might include a biophysical profile. This isn't done in every pregnancy, but it's done in pregnancies that are considered high risk, and it is done when you have a non-reactive, non-stress test. So it's done with ultrasound. There are 5 criteria. You really don't need to memorize these. Just know it's a measure of fetal well-being. They get 2 points or none. There is no half credit given, no partial credit. What I want you to take away from this, these are the things we measure. What I want you to take away from this is that 8 or 10 is good. So the baby could be sleeping and have a non-reactive, non-stress test, but everything else looks reassuring. That's awesome. Or maybe their amniotic fluid volume is a little low, still fine. There's 6 out of 10 we're going to monitor and consider delivering early. And if it's a 4 or 2 or 0, that baby needs to come out. BPP of 4, probably try induction first, but this might be a kid that doesn't tolerate labor. If it's, really urgent, we're probably going to look at C-section delivery. And that is it for today. Any questions? You know where to find me.